Hi, my name is Morgan Thompson-Miles, and I'm a second-year PA student at UTMB. Here's my SOAP Note presentation in my Medicine Block 2 at Center for Advanced Heart Failure located at Southeast Memorial Hermann. So I had this patient October 11, 2018. He's a 79-year-old male, Hispanic, with a past medical history of a recent GI bleed in the last 2 months where he was hospitalized. He also has a history of AFib, hypertension, hyperlipidemia, diabetes, and obstructive sleep apnea. So he presents to the clinic today with increasing fatigue and shortness of breath over the last 8 weeks that wasn't resolved after his hospitalization. He says that he's been off his anticoagulation since he was hospitalized for the GI bleed. And he also admits, sadly, that he has been widowed earlier this year, so he's been living by himself. So he presents to the clinic tachycardic at 113 in AFib with RVR on EKG. He denies any nausea, any vomiting, any fevers, night sweats, no dizziness, no syncope, no chest pain, no palpitations, no hematochezia, no hemoptysis, no dysuria, and no hematuria. Patient has no known drug allergies. He's currently taking, medication-wise, he's taking amiodarone, 200 milligrams daily, atorvastatin, Lipitor, 40 milligrams PO daily. He's taking metformin, 500 milligrams, BID, PO. He's taking metoprolol, 50 milligrams daily, and then he's also taking omeprazole, 40 milligrams daily. So on physical exam, patient, he is ANO times 3. He's in no current distress right now. Neck, no thyromegaly, no other abnormalities noted there. Lungs, they were clear, bilateral to auscultation, equal chest rise, no wheezes, no rhonchi, no use of accessory muscles. Cardio, he does have an irregular heart rhythm. He is tachycardic. S1, S2 are heard. No murmurs, no rubs, no gallops or anything like that. Abdomen, soft, non-tender. Bowel sounds auscultated in all 4 quadrants. No hepatosplenomegaly. Extremities, warm to touch, bilateral, lower extremity edema, +1. No cyanosis though, no clubbing, no ulcers noted. Neuro, cranial nerves 2 through 12 intact. Gait was normal, no instability, and then no focal deficits. To be noted, he did have a decreased hair distribution on his lower extremities, mainly below the knee, but other than that, it was okay. Vital signs. So his heart rate, like I said, was 113, irregular rhythm. His blood pressure was 146 over 72. His temperature, afebrile, 98.3 Fahrenheit. Respirations 18. And his pulse ox, he's 96. He's starting at 96% on room air. Weight is 190. BMI about 29. And then we did get his lab values. His last lab values that was drawn last week. Significant for low hemoglobin. His hemoglobin was 9.7, showing anemia, but he was hospitalized for acute blood loss from an upper GI bleed. So other than that, everything on his CBC seems within normal range. No elevated white blood cells or anything like that, just showing kind of anemia from acute blood loss. So EKG, like I said, it showed he was in atrial fibrillation currently with rapid ventricular response. It was abnormal. His heart rate was irregular. And in addition, the patient has not been on anticoagulation therapy. Which was a little alarming for us. So we decided to address his persistent AFib first. And with that, he did have a higher CHA2DS2-VASc score that we used to assess his risk for stroke. And we ended up, the goals for AFib are to rate control, anticoagulate. So he's already on metoprolol, so we wanted to increase the metoprolol from 50 milligrams to 100 milligrams. And then we needed to add on anticoagulation. And despite him having a history of a recent GI bleed, his hemoglobin isn't severely low. And really, the risk versus benefit, we needed to put on anticoagulation. And so also, since he is at risk for stroke, we need to cardiovert him. Although he has not been on any anticoagulation therapy, so we scheduled an EGD to clear any upper GI bleed, and then as well as a TEE with cardioversion to rule out any signs of clot or thrombus that can lead to a stroke if you cardioavert before they're not on anticoagulation therapy for 3 to 4 weeks. So we scheduled him for that at the beginning of the next week. Also, we want to continue him on the amiodarone, although he is not in a regular rhythm. Continue that, and then we wanted to order another CBC, a CMP for liver function, as well as a TSH since he has been on amiodarone. We also are referring him to cardiovascular surgeon for a potential procedure for Watchman therapy, which is a device that they can use, and they put it in the left mural thrombus in the left atria in order to prevent those clots from forming and staying there that could be dislodged into a stroke, and then so he won't have to be on long-term anticoagulation therapy because he's had a history of GI bleeds. So other problems that we addressed were his anemia, and then we told him to definitely follow up with his GI, which he's planning on, his PCP, as well as watch for any signs of bleeding, and at this time not requiring any kind of packed red blood cell, no blood transfusion necessary. I mean, his hemoglobin was 9.7 last week, but we did instruct him to look out for any kind of bleeding, black stools, any hemoptysis, or anything like that. We also addressed his gastric ulcer, continuing the omeprazole, the PPI, 40 milligrams daily, as well as his hypertension. So he's on the metoprolol that we just increased from 50 milligrams to 100 milligrams. But right now he's at 146, not super hypertensive, especially for his age. And right now the primary problem is his atrial fibrillation. Also his type 2 diabetes, it's been well controlled. He doesn't complain of any issues. He follows up with his PCP for that. He's on 500 milligrams of metformin, so continue taking that BID, as well as his atorvastatin, Lipitor, for his high cholesterol, and we also ordered another lipid panel, and then we ordered a hemoglobin A1C to see where his sugars are at and how stable his diabetes is. He also has obstructive sleep apnea, so we did encourage him to continue his CPAP mask at 11 centimeters per water, because also obstructive sleep apnea can exacerbate atrial fibrillation. So we just want to kind of, address all areas that could be causing and making his problem worse. Following up, he has been instructed to follow up with his GI doctor, his PCP. We're scheduling him for an EGD and then the TE and cardioversion early next week. We addressed any side effects and all his questions. He's educated that any change in his status to definitely come to the emergency room, but we'll be following up closely. All right, so that is my SOAP note for Medicine Block 2, Center for Advanced Heart Failure. Thank you. Bye.